Hi, everybody. I'm Bill Wilmer, nephrologist in the area, Kidney Specialists Incorporated. And I have two talks today, and this is going to be a talk on hypertension from the nephrologist point of view. I'm also part of the National Kidney Foundation of Central Ohio. I'm a board member, medical advisory board as well. And this topic is something that's near and dear to most nephrologists' heart. We see a lot of people in the office as well as the hospital with hypertension, and the nephrologists have a little bit different point of view on how to take care of these folks. So this is a discussion using cases to try to illustrate some of the points on how we take care of patients from the nephrologist point of view. So we'll start off with the first case. And the theme of this case is when to treat and how to treat. So this is a typical patient for those who are primary care providers, or even if you're in the hospital taking care of somebody maybe for the first time. This is a 52-year-old patient, common scenario that you'll see, who has years of smoking, hyperlipidemia. His only medication's a statin, and you notice high blood pressures. And you check blood pressures in both arms, which you really should do for every patient that you first meet with hypertension, just to make sure that there's similarities in each arm. No orthostatic change to the blood pressure. And as you have been taught, you don't necessarily shoot from the hip and say, okay, now you have high blood pressure. You reevaluate this patient at a later time. Those of you, by the way, who are in the hospital and you notice some very, very high blood pressures, also do not shoot from the hip. There's been a recent study, this is not on the slide, showing that you really don't need to treat elevated blood pressures in the hospital. You'll probably do more harm than good. Kind of let the dust settle and see what patients are like when they're not in the hospital setting with anxiety and pain, etc. But anyway, with this patient, you have a follow-up evaluation 1 week later, and yeah, the blood pressures are the same. And then you also ask them at that first meeting, try to get some out of the office blood pressures. Do you have a blood pressure cuff available? Can you get one? If not, maybe we can do even ambulatory 24-hour blood pressure readings. Now, I know the hospital here has that. Our office has that as well. It's not prominent in a lot of other offices, mainly because you can't bill for it. The apparatus is several thousands of dollars. Medicare and commercial insurance won't let us pay bill for it, but we do it kind of out of the generosity of our hearts, and we do it just to get more info on the patient. So at this situation, with this scenario, the question is, should you treat this elevated blood pressure? And if you do, what guidelines do you follow? And unfortunately, every medical entity likes to have their own guidelines. Probably the most prominent and often followed is the Joint National Committee 8, JNC 8. There's a 9 that's coming out soon, which is a combination of cardiologists, endocrinologists, nephrologists, primary care providers, physiologists, et cetera, who build together criteria of diagnosing and treating hypertension. They revise this every few years, and unfortunately for the nephrologists and cardiologists out there, we think they've taken a step backwards in the aggressiveness of blood pressure control. They kind of relaxed some of the blood pressure readings, and they're now treating people only if systolic pressures, for example, are over 140. And then you have the American College of Cardiology and the American Heart Association, as well as international, European, Canadian, and at the very bottom, KDIGO. KDIGO is the National Kidney Foundation Nephrology Guidelines, and KDIGO stands for Kidney Disease Improving Global Outcomes, and it's an international guideline. So you have a lot of different guidelines to follow. The question is, which ones do you follow? So then JNC 8, in this situation, they would suggest if a patient's 60 years or older without diabetes or chronic kidney disease, you should keep the systolic pressure less than 150, which is a radical departure from where they were several years prior. If you're 18 to 59 years of age without these comorbidities, 60 years or older with diabetes, chronic kidney disease, or both, blood pressure should be less than 140. And even at that threshold, many of us are uncomfortable and think that we're probably under-treating patients. So in 2017, American College of Cardiology, American Heart Association made a radical departure of their own and started to say, you know what, don't listen to JNC8, we're going to be much more aggressive. And so they define normal blood pressure as much lower, that elevated blood pressures are between 120 and 129 systolic, and that there's two stages, stage 1 and stage 2 of hypertension, based on the systolic as well as the diastolic blood pressure, as you can read. Now, throughout this talk and other talks, you're going to hear a lot of emphasis on systolic blood pressure, because it's really difficult to know. I'm at goal at systolic, but I'm not at goal at diastolic, or vice versa, and patients get very confused. Most of us in cardiology and in nephrology look at the systolic pressure because that tends to drive most of the end organ damage. So if you look at the ACC, American Heart Association Physiology, a philosophy, their rationale to a nephrologist is quite good, that the risk of cardiovascular disease, the major killer in the United States and across the globe, increases in a log linear fashion from a blood pressure of less than 115 to high blood pressures. So every little gradation above that, your increase of cardiovascular disease increases. For example, a 20 millimeter mercury higher systolic pressure or a 10 of diastolic doubles the risk of death from stroke, heart disease, and vascular disease within a patient's lifespan. As I mentioned, systolic blood pressure has consistently been associated with cardiovascular, and I'll put in there nephrology disease risk as well. So using these guidelines, which you are now understanding we nephrologists like, because as nephrologists, our patients also have extremely high cardiovascular risk scores. You look at the patient kind of with all the other risk factors involved. You don't kind of look at them as a silo of hypertension, but you look at them as an individual who's been a smoker, who has hyperlipidemia, and you delve in further, heart disease, family risk factors, etc. And if you go to this website, cvdrisk.com, and there are other cardiovascular risk evaluators, you can develop a cardiovascular risk score based on all the risk factors. And using this strategy, the patient who we just described, even though he's young, has a cardiovascular risk score of greater than 10% stroke, heart attack, or heart failure within 10 years. And although some people would say that's not that bad, most of us would agree we don't want to take that 10% risk. So the blood pressure goal for this individual, we're going to argue, should be tight, less than 130/80. How do you do this? How do you intervene? Well, earlier initiation of medications, pharmacologic therapy, is indicated for patients with hypertension, pre-existing cardiovascular disease, chronic kidney disease, diabetes, or, as in this patient, a high 10-year cardiovascular disease risk. Lifestyle modification should always be used as well. And we're all taught, when we have somebody with hypertension, we sit them down, we talk about lifestyle modification. Lose weight, low salt diet, exercise, stop smoking. And those of you who have been in practice long enough to know, although some people take this to heart, the majority of people really don't. They are what they are because they've had decades of living in a certain lifestyle. Modifying that lifestyle takes a lot of time, and during that time, cardiovascular disease risk is still present. Also, other risk factors that suggest a low blood pressure, as mentioned, chronic kidney disease, diabetes, and the new wrinkle is patients, your older patient with mild cognitive impairment. So there was a big trial called the SPRINT trial, nothing about the phone company, the SPRINT trial, which looked at blood pressure goals, and they really showed really tight blood pressure goals. Systolics less than 120 benefit cardiovascular disease. Well, there was a SPRINT MIND study, which is cited below this, that showed that if you have somebody who's a little bit older and has cognitive impairment, that if you're aggressive with the blood pressure control, not the opposite, where we sometimes let blood pressures go a little higher, if you're aggressive, you can actually slow vascular dementia from occurring. I mentioned earlier that to this individual and individuals that you're going to be seeing in the office or eventually in the hospital to go outside of the hospital at home, we want to emphasize out of office blood pressure measurement. We all know about white coat hypertension effects, where in the office the blood pressures are high, outside of the office they're not. But there's another condition that has not really been well learned, I guess, it's been well described, called masked hypertension, where blood pressures paradoxically are high at home, but they're okay in your office. And as I sometimes joke my patients, I don't want to know what's going on at home to raise your blood pressure, but if they are high at home, you don't ignore that, and you want to measure that. And to measure out of office blood pressures, we sometimes have to do self-measured blood pressure monitoring. The current digital blood pressure cuffs are fantastic, much better than using a stethoscope and having grandma and grandpa do it. We have, as I said, ambulatory blood pressure monitoring, 24-hour monitoring systems. I would advise you not to emphasize to your patients going to Kroger's or Target and going to a kiosk or using finger or wrist blood pressure monitoring, because they're just not that reliable. To the right of this slide then is a kind of cumbersome table, but it kind of emphasizes what we're talking about. In the left lower part, normotension, where patients both in the out of office as well as in office, the Y and X axis are controlled. And in the right upper corner box, you have sustained hypertension, where you have patients who are elevated blood pressure at home and in the office. But there are individuals who in the office are fine, but they're elevated at home. And there are people who have white coat hypertension only high in the office, but not at home. Of these, the white coat effect probably isn't as important as we used to think. Now, I put a little asterisk there because about 70% of people who have white coat hypertension will eventually develop sustained hypertension. And I put together a little slide from American Heart Association showing on the y-axis cardiovascular events that treated masked hypertension and untreated masked hypertension have a much higher cardiovascular disease risk than the white coat or even normotensive individuals. There was a large study several years ago in Spain where they took a look at the entire managed care population in Spain, hundreds of thousands of individuals, and they showed a significant cardiovascular disease risk for at-home blood pressures that are elevated. So always kind of compare at-home blood pressures with your office blood pressures. So back to the patient, back to case one. You encourage lifestyle modification, and you decide also to start medications. Because as we said, lifestyle modification should be emphasized, but it takes us a long time to change our ways. So which of the following is not an appropriate initial choice of medications? And I listed here an ACE inhibitor, a thiazide, a calcium channel blocker, an ARB, losartan, and atenolol. And I'll give you just a couple minutes to kind of stew on this, or a couple seconds to stew on this, to decide which one would not be an appropriate initial choice. Okay, our answer is the beta blocker, atenolol. An ACE inhibitor, a thiazide diuretic, a calcium channel blocker, or an ARB are excellent choices for first-tier medication for controlling blood pressure. We don't use beta blockers. We don't use loops. We don't use alpha blockers right away. We don't use direct vasodilators like hydralazine or minoxidil. We don't use aldosterone antagonists. And mainly because an ACE inhibitor, ARB, calcium channel blocker and thiazide perhaps give you the best control of blood pressure as well as the best cardiovascular protection. And interestingly, and many people don't know this, that beta blockers are, when they're used as monotherapy, are statistically associated with a much higher stroke risk. And the thought about that is, by slowing heart rate down as well as lowering blood pressure, cerebral vasculature actually tends to spasm at times, tends to tighten, leading to strokes. I'll say this several times in this talk, lifestyle modification should always be emphasized, but we like to use pharmacotherapy because of the slow response for lifestyle modification. This is a very interesting study that I want to show you to emphasize the nephrologist point of view of what to use. So this was the Legend Hypertension study, a very large study. If you take a look down here, 4.8 million patients were reviewed. And basically this is electronic healthcare records, 1 year of data before hypertension was diagnosed, and then a lot of data afterwards looking at pharmacy data, what was filled, what was refilled. And if you take a look at the types of medications used, you'll see that predominantly ACE inhibitors, followed by diuretics, calcium channel blocker, and ARB are used. The non-dihydropyridine, so many of you are not maybe sure of what dihydropyridine calcium channel blocker, that would be your amlodipine and nifedipine. The non-dihydro would be your diltiazem and your verapamil. So those non-dihydropyridines are uncommonly used, as you know. When you look at all this information, MI, hospitalization for heart failure, and stroke risks were reduced more in the thiazide diuretic group than all the other groups. And although low sodium and low potassium were common, there was a tremendous difference between using a thiazide and the other medications. And often, thiazides, diuretics are not what we use first. We use them third, fourth, sometimes fifth. A lot of people come to my partner in my office not on any diuretic at all. So diuretics should be emphasized early. Now, when it comes to thiazides, we have kind of three flavors. We have a very weak thiazide, which I tend to use on my 75, 80-year-old men and women and older. That would be indapamide, followed by hydrochlorothiazide, followed by chlorthalidone. That's the potency of thiazide. So if you're a little worried about the strength of the thiazide, indapamide is a fantastic, weak thiazide diuretic, which is very helpful. Now, case 2, we're talking about a little bit higher blood pressure reading, stage 2 hypertension. The same patient's older brother, also 56-year-old, presents to your office and he says, hey, you've been taking care of my brother. I have high blood pressure and I also have cholesterol, and my brother and I have been smoking same duration of years, and the patient's BMI is high. He's obese, almost obese at 38. And these are his blood pressures, 160s. Out of the office, blood pressures are the same. So how are you going to treat this patient? You already know from the brother that you're going to treat it with lifestyle modification and you're going to use medications. So how are you going to use the medications is what this case is all about. And what you want to do, and what I'm trying to emphasize in this case, is to use combination therapy, lifestyle modification or combination therapy. So if your patient's systolic is 20 millimeters above the goal, diastolic 10 millimeters above the goal, combination therapy is where you need to go. And what do I mean by combination therapy? I mean combination of an ACE inhibitor with a diuretic, an ARB with a diuretic, calcium channel blocker with a diuretic, a combination of medications. This is a really interesting study that came out of Italy to demonstrate the utility of combination therapy. This shows the protective effects of combination therapy versus monotherapy, one drug therapy, in reducing cardiovascular events, 125,000 patients. And it's a little bit cumbersome, and hopefully you've seen a scattergram like this before. The middle line is basically your starting point, comparing basically monotherapy with combination. Anything to the left means that there is a benefit from the combination therapy. Anything to the right would mean that there is not a benefit, there's a harm of the combination therapy. So if you look at any cardiovascular event, heart failure, stroke, ischemic heart disease, or death, starting a patient with that degree of stiff hypertension on combination therapy from the beginning makes sense. So don't tiptoe in the pool, don't tiptoe in the water, go in full blast, combination therapy, get those blood pressures controlled. Why is this relevant? Because we all know life is what it is. Lifestyle modification takes a while. If you send your patient out and ask them to change lifestyle modification without medicines, you may not see them back for a while, or you may not see them back at all. If you start monotherapy and say, I'm going to titrate you up later, that may take months or years for them to come back with the blood pressure reading so you can titrate them. So start aggressive early and you'll have a lot better cardiovascular benefits. Case 3, and this is an interesting area that we're going into. We're going to talk about resistant hypertension, and with that we're going to talk about secondary forms of hypertension as well. Remember, this is from the nephrologist point of view, so there's some things in endocrinology we're not going to touch on here. But this is a very common case. You'll see individuals like this all the time. A 45-year-old female, hypertension for 2 years, blood pressures are high at home, reporting headaches, but she's already taking lisinopril at a pretty good dose, hydrochlorothiazide at a pretty good dose, nifedipine XL at a really significant dose. She exercises, she has a low salt diet, she's lean, she's doing great, but she's still hypertensive. And her hypertension's kind of checked in the office and checked at home, and all the blood pressure readings are the same. So what is the next medication you add to the ACE inhibitor, the calcium channel blocker, and the diuretic? What's the next step? Because believe me, in my referral practice, in my partner in my practice, we see everything. We see all kinds of combinations of medications. And so do you add a beta blocker now, an alpha blocker, a loop diuretic, or a mineralocorticoid receptor blocker such as spironolactone? Well, so you don't have to guess. The homework has already been done. And it was done showing that mineralocorticoid receptor blockers are probably the best. And it was done by an Australian group, and we'll talk about that in just a second. This patient has what we call resistant hypertension, and you'll see the terms resistant hypertension and refractory hypertension used all the time. And so there are basically definitions for both. Resistant hypertension is uncontrolled hypertension using moderate to high doses of 3 medications, of which one has to be a diuretic. So I sometimes see patients and they're like, oh, we have resistant hypertension, and they're on a beta blocker, calcium channel blocker, ACE inhibitor, ARB, clonidine, but they're not on a diuretic. They are in essence not resistant hypertension unless you diurese them. And refractory is basically the same, using 5 medications. And refractory hypertension obviously tells us something is wrong. Secondary forms of hypertension should be looked for. This is the answer to using mineralocorticoid receptor blockers. This is the Pathway 2 trial. It was published in 2015, a very large Australian trial. I didn't put the number of patients, but it was hundreds of thousands of patients that were looked at. And if you look all the way to the left, this is baseline therapy. This is a trial looking at what's your 4th choice? What's your 4th tier medicine? ACE inhibitor, calcium channel blocker, ACE inhibitor or ARB, calcium channel blocker, and diuretic are already used, but the patients are still hypertensive. So in this trial, they did nothing, which is placebo. They added spironolactone, doxazosin, which is an alpha blocker, and then they used bisoprolol, which is a beta blocker. And as you see, you get more bang for your buck with spironolactone, either 25 to 50 milligrams a day. The entire trial of this were thousands of patients. Those who followed in the fourth tier, the numbers are down below, and you see there's several hundred, not the thousands. So pathway 2 let us know maybe there's something to aldosterone. Maybe there's something to aldosterone that's causing refractory or resistant hypertension. So just to kind of go back to medical school or nursing school physiology, this is the pathway that we spend a whole lot of time trying to antagonize. This is the renin-angiotensin aldosterone system. Just to review how it works, angiotensin basically gives rise to angiotensin 1, and that is stimulated by a kidney hormone called renin. Renin is made by the kidney filter, the glomerulus. And it is made if the kidney and all the structures around the kidney are sensing low blood flow, whether that be dehydration, bleeding, low blood pressure, cardiomyopathy, and low cardiac output. Renin is stimulated. And so that stimulates angiotensin 1 to be made by angiotensin, that stimulates the production of angiotensin 1. Then angiotensin 2 is produced by an enzyme we all know very well, angiotensin converting enzymes. We use the angiotensin converting enzyme inhibitors all the time, like lisinopril, enalapril, etc. It just so happens, by the way, that in my patient population, chronic kidney disease patients, we often have ACE inhibitors that don't work well because there's another hormone that's out there called chymase, which is upregulated in chronic kidney disease that can make the conversion to angiotensin 2 still happen. For angiotensin 2, there's two different receptors. I put that on the right side. There's an angiotensin type 1 receptor and a type 2 receptor. It just so happens that the type 1 receptor is the bad one. It's the one that causes vasoconstriction. It activates endothelial cells within blood vessels, causing scar formation, and it on its own causes sodium and water retention. And then that gives rise to aldosterone. And aldosterone made in the adrenal gland is very, very potent at holding on to salt and water. The last segment of the kidney tubules, as the tubules modify urine, aldosterone works and will pull salt and water out of the urine back into the bloodstream very aggressively. That system is what we try to antagonize, ACE inhibitors and ARBs. But unfortunately, aldosterone can be made independent of this pathway. We've always thought of it through this pathway, but it can be made independently of this pathway. The pituitary hormone ACTH can stimulate it. Hyperkalemia can stimulate it. Think about how many people on an ACE inhibitor or ARB or high potassium diet, how many people have high potassium levels? Why does that happen? Well, aldosterone, in addition to holding on to salt and water, also is responsible for making the kidneys pee out, excrete potassium. So if you have high potassium, the body's response is stimulate aldosterone and get rid of the potassium through the kidneys. So high potassium will do it. And then very interestingly, a couple years ago, it was shown that adipocytes, fat cells, make aldosterone. And they can make enough aldosterone that they have biological effects. And just automatically think about many of your patients, obese. Obesity and hypertension, we've always said what it might be, your body size is contributing to it, your salt intake is contributing to it, but we now think that aldosterone excess from the fat cells might be contributing to it. Many patients who we have on an ACE inhibitor or ARB will have excessive amounts of aldosterone in their system. And this is kind of a new concept, only developed in the last several years. So this slide shows in the green line, you have somebody with blood pressure, and this on the y-axis, this is aldosterone levels, at which time you're measuring them during ACE inhibitor use or ARB use, the angiotensin axis. And as expected, when you use these medications, your aldosterone levels drop, as they're supposed to. But in a portion of individuals, over time, aldosterone levels will start to pick up. There will be a breakthrough physiology where, even though you think you're doing a great job with your ACE inhibitor dose and your ARB dose, we're not. We have a lot of aldosterone in the system. So many of you have referred to me, or my partners know that we'll get an aldosterone level on an ACE inhibitor or ARB, and if they're elevated, to us, that's evidence of breakthrough physiology. We can't predict who's going to do that. We just know when blood pressures aren't coming under control on the medicines that they're supposed to, then we look for aldosterone. And that's why that Pathway 2 trial showing spironolactone may be helpful, antagonizing aldosterone, why this may work. I'm going to shift for just a second to secondary causes of hypertension, which you should consider when you have a patient with resistant or refractory hypertension, because this dovetails beautifully with our emphasis on aldosterone, which as a nephrologist is in my wheelhouse. There are what we consider endocrine causes of hypertension, Cushing's and hyperparathyroidism and PHIO. Everybody looks for a PHIO. That's the zebra that we all look for. Every now and then we'll find one. But on the top list are the most likely etiologies, the non-endocrine causes for resistant hypertension. Sleep apnea is a big one. We refer a lot of people for sleep studies. And if you have sleep apnea and you treat it, your systolic pressures may drop 5 to 7, maybe 8 points with good treatment. Chronic kidney disease, kidneys can't get rid of salt and water, you're going to have hypertension. There are other reasons chronic kidney disease can do this as well. I won't go into that. And then you have hyperaldosteronism, primary hyperaldosteronism, and then renal artery stenosis, and then I'm going to throw in there a congenital problem, fibromuscular dysplasia. We see that in young females more than males. That causes a form of hyperaldosteronism called secondary, where because of excessive renin from low flow to the kidney, remember I showed you on that diagram, renin is made when low flow to the kidney is occurring, heart failure, dehydration. Add to that renal artery narrowing, either it be atherosclerosis or fibromuscular dysplasia, renin levels start to crank up massively, and that fuels angiotensin II and aldosterone. Medications, nonsteroidals, nasal sprays, transplant patients who are on cyclosporin, and then patients who are on Procrit, Retacrit, EPO. Anytime we see that and we start increasing the hematocrit, we're increasing blood pressure. So patients who are anemic and start getting erythropoiesis with these medications often need adjustments in their blood pressures. And then alcohol excess. Alcoholics tend to have higher blood pressures. And so we really have to think of that as a risk factor for resistant hypertension. Now I'm going to take of these secondary forms, I'm going to again put more emphasis on our friend aldosterone. Hyperaldosteronism. Hyperaldosteronism, when I was younger, was thought to be kind of an uncommon entity, where the adrenal glands on their own are making too much aldosterone, or through renal artery stenosis as a secondary form are making too much aldosterone. But the prevalence is much greater than we ever thought. Some really elegant studies over the last couple of years have shown that in resistant hypertension, up to 20 to 25% of cases may be because of aldosterone excess, whether that be that breakthrough, aldosterone breakthrough physiology, or truly an adenoma or hyperplasia or something wrong with the adrenal gland pumping out aldosterone. That's interesting, but guess what? We don't look for it. In a study that was published just a couple years ago, looking at 4,660 patients with resistant hypertension at one center, only 2% of the patients had any workup for hyperaldosteronism. We just don't think about it. And why don't we think about it? Because our old teaching was that you don't think about hyperaldosteronism unless a patient has severely low potassium. Remember, aldosterone holds on to salt and water and makes the kidneys excrete potassium. So the old school way of thinking about this is look for it if potassiums are low and you don't really know why they're low. But guess what? That doesn't hold water. Usually low potassium occurs, but not always. And many times when you have a hypertensive patient, their potassium will not be low at all. And then they start to get low if you just add even a low dose of a diuretic. So aldosterone excess can be there with a normal potassium. It can be shown if you start a diuretic and it barely drops a little bit. So you have to think about it in resistant hypertension. Look at your serum CO2, serum bicarb, because as aldosterone makes the kidneys get rid of potassium, they also make the kidneys get rid of hydrogen ions, acid. So what happens over time when you have a lot of aldosterone is your serum CO2, your serum bicarbonate starts to increase. Instead of 25, 27, 28, 30, 32, when you have a high bicarb, low potassium, resistant hypertension, you got to think about aldosterone. As we mentioned, primary, something's going on with the adrenal glands. Secondary, something's going on with the renal arteries. If you think you have all the diagnostic criteria for hyperaldosteronism, if you think this might be primary, and you say, I want to get a picture of this, I want to get an imaging, CT scans or MRIs are the way to go. But when you order these, you have to let the techs and the radiologists know you're doing adrenal imaging. The adrenal gland's about the size of my pinky. And so if you do a standard CT or MRI and they do a standard cut, they're going to miss the entire adrenal gland. So sometimes adenomas are really, really tiny, and if you don't ask for a special view, you're going to miss the adenoma. So in your office or in the hospital, you can do this workup. And aldosterone measurements with renin measurements will give you abundant insight into your patients with resistant hypertension. No matter what the result, you're going to learn something about your patient. And I'm going to kind of pick through it here. I know this is a busy slide, but it's pretty much common sense. First of all, you want to hold an ACE inhibitor, ARB, and spironolactone, mineralocorticoid receptor, for a couple of days before you measure this stuff. And that's a little risky because you're going to be afraid blood pressures go too high. But you want basically a clean slate when you measure these things. You want to get an early morning sitting renin and aldosterone. And you'll notice on the renin, it's going to come back as a rate. It's the number of nanograms per ml of hour of conversion of a substrate. It's a very weird thing. So it's a rate of conversion. So the way they test for renin is they look for a test chemical to see if it's converted and how much of it's converted over time. Plasma renin levels should be low in primary hyperaldosteronism. The aldosterone excess made by the adrenal glands is going to expand your volume so much, it's going to expand your blood pressure so much that renal blood flow is going to be juicy. You're going to have a lot of flow there, and renin is going to be turned off. If renin is elevated and your aldosterone is elevated, then that tells you you've got a renal artery problem, low flow, or congestive heart failure will do the same. Below I have certain scenarios, and we look at the ratio of aldosterone to renin to give us an idea. If your aldosterone to renin value is 30-1, even if your potassium's normal, you probably have primary hyperaldosteronism in front of you. If it's 20-1, aldosterone to renin level, 20-1, and your potassium's low, you probably have hyperaldosteronism. Now, I'm going to just put a little wrinkle in there, and I didn't put this on the slide. Many times, renin values are so suppressed, the lab's going to say less than 0.5. And you're going to say, how do I do a ratio with a less than in the denominator. Well, in that situation, just make renin 0.5. Just make it 0.5. That's the lowest level, and then do your ratio with that. Now onward. Aldosterone to renin ratio is 10 to 1. Maybe there's a problem going on, so we have to take it another step. And this is going to kind of undo many of you, but you can order a 24-hour urine aldosterone. Very easy to order. Got to show the lab that you're doing that, because they're going to have the patient put a preservative in the urine. And from that, you'll see a normal level of aldosterone and see if the patient has excessive amounts of aldosterone excretion in 24 hours. And then if your aldo level is less than 10 to 1, even if your potassium's low, you probably don't have hyperaldosteronism, okay? So the ratios will tell us a lot, whether you may have it or you are likely to have it or somewhere in between. And in fact, no matter what the ratios are, whatever the levels are, you're going to learn something about your patient, okay? And I've got 4 scenarios, A, B, C, and D at the bottom. And I've got 4 different lab possible results. And I'm going to ask you to match these, okay? I'm going to ask you to match these. Where number 1, the renin value is super low and the aldosterone value is super low. Think about that. You're not making renin and you're not making aldo. You'll see this in a lot of patients. Number 2, your renin value is high and your aldosterone value is high. Okay? Renin from the kidney artery to the kidney, renin values are high, aldosterone's high. The third one I haven't really talked about, but you'll see this as well. The renin values are through the roof, 30, and aldosterone levels are suppressed. What in the world's going on there? And then fourth, your renin values are very low, 0.5, and your aldosterone levels are high. Is this renal artery stenosis, primary hyperaldo, volume expanded state, or ACE inhibitor therapy? So we'll go to the answers here real quick. Let's take them one at a time, and we'll go down to the scenarios, and I'll explain it. Again, renin and aldo levels are going to teach you about your patient no matter what the values. So renal artery stenosis, number 2. Renal artery stenosis will cause high renin and high aldo. When you see that, you got to think about renal artery disease from atherosclerosis or fibromuscular dysplasia. Let's go to primary hyperaldosteronism. That should suppress your aldo. So that, and number 4, renin is suppressed, aldosterone's elevated. That's primary hyperaldo. C, I haven't really talked about, but you're all smart enough to figure this out. If your renin is suppressed and your aldo suppressed, that's because the patient's volume is huge. They have volume expanded state, a fluid overloaded state. And in some situations, there's a syndrome called Lytle syndrome. I'll let you Google that on your own. I won't give you a physiologic talk on Lytle syndrome. But there are genetic reasons for this as well. Most of the time, these are patients who are on a high salt diet. They're not on a diuretic. They're edematous. They're volume expanded. And so even on an ACE inhibitor, even on an ARB, their volume expanded. And so there is no renin and there is no aldo because their volume is expanded. So your ACE inhibitor and your losartan and all that is doing nothing to help the patient's blood pressure. That's why you need diuretics. And the fourth scenario is an ACE inhibitor therapy or ARB therapy. And remember what I told you. When you inhibit that angiotensin 1 to 2, renin values will start to build up. So what happens is when you have good ACE inhibitor and ARB therapy, you will not be producing aldosterone. Your aldo levels will be low, but there will be this buildup of renin behind it. So the renin value, number 3, of 30, super high, and aldo levels that are low shows that the ACE inhibitor and ARB is working. Renin values are backed up and your aldosterone levels are low as they should be. Now, I didn't put this down, but just think this through. What if the renin was 30 and the aldo level was 20? That goes back to the aldosterone breakthrough physiology I introduced to you earlier. And if that aldo level is high, even if the renin's high, if that aldo is high, think about a mineralocorticoid receptor blocker. So, just a quick summary. Emphasize when you're taking care of people with high blood pressure, home blood pressures, out of the office blood pressures. At risk of cardiovascular disease, be very aggressive with blood pressure control. Diuretics early, thiazides early. Combination therapy with really high blood pressures from the outset. Resistant hypertension, the Pathway 2 trial. As a fourth line, use a mineralocorticoid receptor blocker, aldactone or Inspra. You will notice that the new kid on the block, finerenone, I didn't put this on the slide, Kerendia, which a lot of the pharmaceutical reps are really suggesting we use, particularly with chronic kidney disease, that's not on the list. Finerenone does not lower blood pressures like the other two. Look for secondary forms of hypertension, and remember that hyperaldosteronism as a form of secondary hypertension is much more common than we think. Thank you.